The decision tool was developed by the Diabetes Care Program to help you determine if testing is required in individuals with non-insulin using type 2 diabetes. The tool will help guide your decision on who needs to test, and for those who do need to test, how often they should test and for how long. The purpose of this video is to introduce the features of the tool, work through a sample case together, provide summary caveats and principles to guide future application of the tool, and to leave you with a few cases to work through at your own pace.
It would be so much easier if we just said test everybody. What happens here is we're going to individualize the testing. So the person who's sitting in front of you is not going to get a sort of cookie cutter approach. You have to sit there and decide with the patient on how often they should test or if they should test at all. Not only that, the person coming to sit in front of you who has been testing for years, you may suddenly now have to have a discussion about why they no longer need to test. Big paradigm shift for us here. So what the tool will go through is, does the person need to test, and if so, why? Are they interested in testing, willing and able to test? Because it doesn't matter if they should test if they can't, right? Can they interpret and act on the results? In other words, it's okay to look at what the results are, but if they can't do anything based on those results, why are they testing? And finally, do we as providers need to see the test for some other reason? And if all of these line up so that we decide that we're going to test, the question is, how often? What's the minimum amount of time or times per day you should be testing? For how long is the other thing. So the tool that you have in front of you can be used individually or can be used in groups. It tends to work well in both. It'll have indications for testing, who should test, and we're going to go through all of this. Provides the required conditions, what do you have to have in place in order for the person to be testing. It does give you a little wiggle room that's saying even though it might not meet the criteria, we as providers still feel there might be an indication for testing over the short term. So that's the wiggle room in the self-management section. And then we actually give you some examples of low and high intensity testing, and always focus on the time limited aspect of it. Don't ask them to test unless you expect that there's a result of that. Okay, so this is the tool, and it's nice and color-coded. The first part is the instructions. The second part are the criteria for testing. The third part would be the recommendations and the examples of low and high intensity testing. And we'll go through each of these in turn. So in the instructions, there'll be yes, no responses. We put some things in parentheses, just some examples to kind of prompt you to think about situations where you would or would not test. The pink areas are the indications, and the indications are very simple. You're going to test if they're hyperglycemic, moderately or severely, or you're going to test you if you have concerns over hypoglycemia. The green are the required conditions. What has to be present if you've decided that they should test? And the white area, again, is even if you do not fulfill all the criteria, if you feel there's still another reason to test, you may do so. This will become more clear as we go through the tool itself. Okay, so here are the key areas for consideration. So from a safety perspective, when should they be testing? So what we have decided upon is there moderate to severe hyperglycemia? And what we've defined that as is an A1C of greater than 8.5%, or a before meal blood glucose averaging 10 or 12. If you're planning on doing a treatment change, if you've just added secretagogue, or you're considering adding insulin because of hyperglycemia, all may be indications for treatment. If there is a worry or concern about hypoglycemia, either the patient is giving you a history of that, you've added a secretagogue, you've added a second medication to a secretagogue, and you have concerns, again, maybe an indication for treating. But that's about it. Okay. Now, from the healthcare team, will we as a healthcare team do something based on what we're seeing in the book? If the answer is yes, then there may be an indication for testing. If the answer is no, why would they be doing it in the first place? And how many patients have come to you and said, I have shown my doctor my book for 20 years and nobody ever looks at my book? And it's finally we're questioning why we're doing this. So somebody has to be looking at these results. They are time sensitive. So given that, is the individual themselves willing and able to actually test and record? If they are they able to interpret and act on the results? And it'll become apparent in some of the examples what we mean by that portion. The self-management education, what a lot of the educators have said to us, even when they first come in, it's part of their education to measure it and to learn what it means to have high blood sugar. So that's your wiggle room section, and that's the controversial one. And at the end is the recommendations. Either no self-monitoring of blood glucose is required, low intensity, which is time limited, or high intensity, which is time limited, and we'll go over those examples with you later. So the low intensity testing, for the most part, that maybe someone may say, look, I'm feeling weak after I exercise. So you may teach them how to do self-monitoring of blood glucose and say, after you exercise, measure your blood glucose. What you're looking for, you're wanting to consider if they're hypoglycemic at the time. Or they may be newly diagnosed and they don't understand their patterns. They said, what am I eating? How is that affecting what I'm doing? You might want to measure sort of 3 tests a day for 2 days a week just to give them an idea of what that means to them. You can do it as little as 1 test per week between office visits. But if you're doing it that infrequently, the question is, why are you doing it at all? And the plan for physicians to measure control over time, the A1C is what is going to tell you about their control, not the self-monitoring of blood glucose. High intensity testing, I myself will be using this in patients who I'm contemplating moving on to insulin. In other words, their control is bad, they're on maximal oral agents, and I'm having difficulty, so I'll be looking for pattern testing. In other words, where are they highest? Where do I want to start the insulin, at breakfast or at supper time? And these will be similar to the patterns you would see in our type 1s, right? You'll be measuring them 5 or 7 times a day. Again, over a short period of time, just to see the pattern. These should be very short-lived, and you should be making a medication change as a result. I should note that none of this applies to gestational diabetes, which is an entirely different kettle of fish, and where there is good evidence that frequent measuring makes a difference. These apply to non-pregnant females in the whole process. So are we ready to try a sample? Okay. Now in the first one, I'm going to give you the answers, but in the rest of them, we're going to go through the answers because, you know, this is very individualized, not only for the patient, but for the practitioner. And so that there probably are no right answers. It just makes us think about the issues that we need to address when we're seeing someone in front of us who has the problem. So our first case here is a 55-year-old male. He's a computer programmer. His fasting glucose is 4.6 to 6.5. He has an A1C of 6.4. We're very happy to see this. He's obviously very motivated. He had a BMI of 33 to start. It's now 29, so he's taken your advice to heart and is working on diet and exercise. Has 3 meals plus an occasional snack. His meal balance is excellent. He's walking 4 times a week. He's going to aerobic classes. This is the dream person with diabetes. He's done exactly what he needs to do. Now currently, he is testing 2 to 3 times per week, twice a day staggered, and he's recording the results and kind of bases his walks depending on his results and anticipated food intake. Okay, so let's run through the tool with this guy and see what we come up with. So here's the tool. So does this person have moderate to severe hyperglycemia? No. No, he does not. So we'll put a no there. Isn't modern technology wonderful? All right. Is there a risk of hypoglycemia? Well, no, he's not on any medication. So the answer there is no. So immediately from a safety perspective, there is no indication for this person to test. But let's continue. Will the healthcare team take appropriate or timely action? Will we change management based on his current blood glucose results? No, he's a target. We're not going to do anything with this. So the answer is no. All right. Is he willing and able to test? Yes. Sure he is. Yeah. Is he willing and able to interpret and act on the results? Yes. Well, the answer is no. What can he do?
Isn't he basing his food and activity on his glucose results? Is that a motivator for him to continue to walk?
Could be, but I suspect that he's probably overemphasizing that. But he cannot act. He is doing the maximum that he can do to control his disease off therapy. So he himself is probably not capable of doing anything else than what he's already doing. So he can't do anything differently based on these results. But you know, this is a plus minus. I would give you that as well. Is education in self-monitoring of blood glucose essential at this point due to safety or other provider reasons? No. Okay. So what's our recommendation? No. Tell them to stop testing. Okay. So no testing required at this time. Now, the difficulty here is this is someone who's been testing regularly. So you'd have to have a little chat about maybe testing once a day. And maybe then after a couple of weeks reducing that to once every couple of days, and then maybe once a week, and then tell them, you know, it's probably okay, you're doing so well, why don't you stop? Because your therapy will be followed by us and your family doctor, your treatment, your successes, and we'll measure your Q3, 4 monthly blood work, your A1C will guide us as to the success of your therapy. Does everyone feel comfortable with that? Yeah? Okay. Okay, so the vast majority of this population do not need to test. And if they do test, it's over a very short period of time with an endpoint. You know, you're testing because I'm going to call you. I need to look at your results. We're going to add new medications. So again, when there are safety issues, hypoglycemic risks, and we know from the studies that the risks of hypoglycemia with sulfonylurea are way overplayed, that they are actually quite infrequent. So I suspect that it's more with exercise that we're going to see it. If there is a planned treatment change, the addition of a second or third oral agent, or the addition of insulin, I think there is a short-term indication to test more frequently to get the patterns that are in place. If there's a compelling reason, despite no responses, in other words, you as a provider get the sixth sense, similar to the question that you just raised, I really do think this is going to help this person over the short term. I mean, you're allowed to do it. There's not going to be a trap door in the floor that's going to drop you through if you actually decide to provide them with a testing for a short time. And it is going to be necessary over time to wean frequent routine testers off their strips. So just remember what we talked about before. You always use your judgment. Big Brother will not be watching you, but remember that there's no evidence of benefit. There is a cost to the individual and to the system. There is potential harm. And I think that was the most distressing part of the studies, that the only thing that came up as positive was the fact that people are more anxious if they're told to test. And wastage with no use results is a really important point. The time-limited concept, if you do decide to test, the next thing that has to pop into your brain is for how long and what is my plan? So if you're going to do how long, are you going to phone in, check with your doctor next week and make sure they tell you to stop? But you're probably going to have to say to your patients, after this time, you no longer have to test. You can now stop testing. The high intensity really are those that are moving toward insulin. There may be, you know, if they're ill and they're starting to drink a lot, you might start to test more frequently at that point. But for the most part, if you're actually saying, you know, we're failing oral therapy, we're going to have to start talking about insulin. You want to probably add the insulin to the oral therapy. You want to pick the time of the day. You have to have a sense of the patterns of when they're high, and that's absolutely reasonable. The low intensity testing is largely making us more comfortable with the idea. You know? So again, it may be the example that we had of the patient who'd like to test for a time, or it may be that we as educators just really feel that it's important for them to know what their sugars are. So even if it's negative to everything, that white area about the self-management piece gives you the opportunity to say, I still think they should do it. But again, very intermittently and always over a short period of time with a plan to have them stop. Now for newly diagnosed and no indications, what we just talked about, if you feel it's an integral part of your teaching, it's okay to do. But again, it should be low intensity and over very short time periods.